So when we drive a car, there are two levers that we look into. We have the accelerator, we have the brake. And we know that in driving, you can't press both of them. You have to either press the accelerator or the brake. And unfortunately, in diabetes, again, we have something similar. We have insulin, which works to put a brake on the hepatic glucose output. And we have glucagon, which serves like the accelerator, increasing the glucose output from the liver. So we see clearly diabetes is a two hormonal problem. It's not a single hormone of insulin, but unfortunately our training has been focused more on insulin, either its deficiency or resistance, and we have forgotten about the important hormone glucagon. And nature has been so creative that it has kept all these cells, the alpha cells, the beta cells which produce insulin, the alpha cells which produce glucagon, and also the delta cells which produce somatostatin, which is also known as the second brake for glucose output. All of them are in the same organ, pancreas. And what we see in type 1 diabetes, because of the deficiency of insulin, there is no brake on the glucagon, and there is a hyperglucagonemia which is present in type 1 diabetes. And similarly in type 2 diabetes, because of the elevated insulin resistance, there is no impedance to the glucagon rise, and there is a hyperglucagonemia also seen in type 2 diabetes. So this is clearly a bihormonal problem, and therefore we should treat it as such and not look at the insulin action alone. And the reason for this insulin centric diabetes care is basically because insulin deficiency is very dramatic and easily visible to all of us, and therefore the alpha cell dysfunction was ignored, and hyperglycemia was almost always equated with either deficient insulin action or resistance to insulin. And treatment strategies also focused only on insulin and its correction, and we ignored the weight gain of insulin as well as the hypoglycemia as inevitable, and that's what has compromised diabetes care. If you look at what controls the glucagon secretion, it is the hypoglycemia, the amino acids, as well as the beta cell failure. And when we look at what is the effect of excess glucagon, it is hepatic glucose production being increased as a result of both glycogenolysis as well as gluconeogenesis. So we need to suppress this glucagon if we need effective glucose control. And what does glucagon actually do? It's a survival hormone. Basically, when we are fasting, it has to prevent hypoglycemia by increasing the hepatic glucose output. And insulin is one which works in the reverse, restraining the glucose secretion after a meal. So therefore, you have a balancing hormones of insulin and glucagon which work on the liver, and pathology happens because of an imbalance of both of them. And most important glucose regulator is the liver because of the hepatic glucose output. And here you see that these two hormones work like a thermostat, and in diabetes what happens is this thermostat is reset at a higher level, and the glucagon is a hormone which is the dominant driver of this reset. Now, what happens to beta cell in type 2 diabetes is something which all of us are familiar, but if you look at the alpha cell dysfunction, they lose the responsiveness to glucose levels, and this not only results in hyperglycemia but also results in hypoglycemia when the patient doesn't eat on time or has an inappropriate insulin levels. So the liver is receiving a constant fasting signal with alpha cell dysfunction, and if you look at the hormone levels in normal individuals as well as in type 2 diabetes, we see after an intake of oral glucose in a normal physiology, the glucagon levels should come down post the ingestion of glucose, whereas in type 2 diabetes, it still remains elevated post the oral glucose intake. And why do we see this hyperglucagonemia? It's because of the declining beta cell function as well as the insulin resistance, and also the sensation of glucose by the alpha cells is also impaired, and you also have the hepatic insulin resistance which amplifies the effect of glucagon. And this dysregulation is worsened progressively with the duration of diabetes. And clinically, we can identify hyperglucagonemia by the elevated fasting plasma glucose, which even remains elevated despite an increased basal insulin injection. And also the postprandial excursions. For example, if somebody eats a single roti and the sugar fasting which was 100 becomes 300, we should be clear that this is not just because of the insulin deficiency, it is also because of the hyperglucagonemia. And therefore, we should focus our attention to the correction of this hyperglucagonemia rather than just focusing on the insulin secretion. And in such a scenario where the pathophysiology is with the increased levels of glucagon, just increasing the dose of insulin will not help, and that's many reasons where many of our patients who receive hundreds of units of insulin are unable to control their sugars because we need to tackle this glucagon levels. And therefore, we should focus on the mechanism. And if you look at what glucagon does to the body, it's not just about glucose, it also works on the hepatic fatty acid oxidation as well as increasing the total daily energy expenditure. And as we are familiar with the SGLT2 inhibitors, it promotes ketogenesis during prolonged fasting, and this dysregulation of fat as well as the total daily energy expenditure coming from the glucagon imbalance, it not only is a risk but also creates a therapeutic opportunity for us, which the GLP analogs have now begun to handle. So what we see is when we suppress the inappropriate glucagon, the hepatic glucose production decreases almost immediately, improving the fasting glucose as well as the postprandial glucose, and whatever insulin dosage that we are giving can be reduced, and the most important thing is the glycemic variability gets reduced, and we can achieve better HbA1c control with lower incidences of hypoglycemia. If you look at type 1 diabetes and see if correcting the hyperglycagonemia is going to help, we have multiple studies showing how correcting the hyperglucagonemia improved the mean CGM glucose by 27, improving the time in range as well as reduced incidence of hypoglycemia. So these are some of the studies with the molecules such as the olaglipimab. Then you have liraglutide, which is the GLP-1 analog, which shows a clear reduction of glucagon almost by 72% when we administer liraglutide, as well as the postprandial glucose reduction by 21%. So what we can achieve by activating the glucagon receptor is an increase in the both resting as well as the postprandial energy expenditure, promoting the fatty acid oxidation as well as weight reduction. So we must understand that the GLP analogs produce the weight loss predominantly by not just the GLP-1 receptor activation, but also by activating the glucagon receptors. And we have a countering of the metabolic slowdown which happens during caloric restriction, and the hepatic lipid handling can be improved by activating the glucagon receptor. So as we are going to see in the coming few days, there are going to be glucagon receptor agonists also, which are going to come into the market, playing a dominant role in metabolic management. So all of us are aware of the GLP-1 receptor agonists, how they work, and one of the key mechanisms is the suppression of the glucagon secretion, which happens in a glucose dependent manner, therefore not causing hypoglycemia, and we know that they also cause gastric emptying and reducing appetite through the central nervous mechanisms. DPP-4 inhibitors are also known to produce a modest glucagon suppression and therefore physiological glucose lowering without much of hypoglycemia as well as weight gain. So, we are going to see a flood of GLP-1 molecules coming in the next few years. We have dual GLP which is already there in the market in the form of tirzepatide, which stimulates both GLP as well as GAP. But what is interesting is to look at glucagon agonists. Some of them put here survodutide, cotadutide and pemvidutide. These are difficult to pronounce. You also have a triple agonist in the form of retatrutide, which are agonists for both GLP, GAP as well as glucagon. So, what is the role of glucagon in hypoglycemia? The ADA 2025 guidelines recommend us to prescribe glucagon for all the patients who are on insulin and preferably use products which don't need reconstitution, which are ready to inject, and also need to give education to the patients. And some of them who are at high risk for hypoglycemia, those who have hypoglycemia unawareness, those who have long duration of diabetes, elderly patients, those with CKD, those who are having with alcohol. And sometimes the traditional glucagon has failed because of the difficulty of reconstitution during emergencies, and sometimes the caregivers don't have confidence to use it, and still we are seeing less prescription of glucagon injections. And today we have better modes of administration of glucagon in the form of intranasal sprays, auto injectors and ready to use analog injections also. Sometimes we need to be aware that glucagon can work only in the presence of good hepatic glycogen, and in situations such as starvation, adrenal insufficiency or chronic hypoglycemia, there will be a reduction in the glycogen content, and this glucagon injections may not work, and there are some contraindications such as pheochromocytoma, insulinoma or hypersensitivity where we cannot use glucagon. A simple rule that we can use in hypoglycemia is, if the patient can swallow, always try to give oral glucose, and if they cannot swallow and you are in a situation where you cannot get IV access, that's where glucagon is ideally given. And when you have IV access, the preferred modality of treatment is giving IV dextrose. So where is the field going to? Like I said, they are going to be glucagon agonists, either as triple agonists or dual agonists, and the glucagon suppression, the most important carry home message is, whenever the fasting glucose is high, think of liver and think of glucagon, and just don't escalate the insulin dose. Use incretins early in the diabetes journey and treat the physiology. And when you talk of glucagon agonism, we need to target the metabolism, and it has also shown that it works better for obesity as well as fatty liver disease, and glycemia is something that we must be monitoring and definitely needs a combination therapy. So think bihormonal whenever there is a glucose imbalance, and in type 1 diabetes the hypoglycemia glucagon response is impaired, which can lead to a lot of variability. We need to prescribe rescue glucagon for everybody who is on insulin, and preferably with a no reconstitution device, and we need to train the patient care providers to use glucagon and store it where they can access it. We also need to know where glucagon cannot work and where we need to use other modalities of treatment of hypoglycemia. Thank you.